So switching gears to thyroid. So thyroid is a critical hormone. You need it for all metabolic processes to occur. Thyroid hormone does a lot of things in all the cells, right? All of our cells over here in this general area, right, on the right in green and blue. So thyroid hormone is what makes you metabolize, right? What do you metabolize? Glucose. You metabolize lipids and proteins too, but you are going to use thyroid hormone to raise your basal metabolic rate. What is basal? Your baseline. What's metabolism? The breakdown of glucose, right? And mostly, that's the technically catabolism, but you're going to be breaking down more glucose overall. You're increasing your BMR with thyroid hormone. You need that to metabolize stuff. Otherwise, you're not gonna feel great, right? You're gonna have a buildup of glucose. You might get hyperglycemic if you are hypothyroid, for instance, right? Because you're not utilizing all the glucose in all of our cellular processes. We'll spell that out, that equation, on the next slide. But thyroid hormone is going to be used for basal metabolic rate. It's also what primes all of your cells with beta receptors, with adrenergic receptors. It's what makes your receptors make beta 1s and beta 2s and alpha 1s, right? So if you don't have thyroid hormone, you don't have beta 1s, beta 2s, and alpha 1s. Therefore, I have what? I have bradycardia and hypotension, right? As a side effect for hypothyroid. Also metabolism for the brain. I'm going to probably feel a little bit confused and lethargic and even comatose if I don't have thyroid hormone, right? Compared to too much thyroid hormone. I have too much beta 1 activity. I have too much tachycardia. I have too much blood pressure, right? And I have too much BMR. I have too much, I'm alert all the time. I'm anxious all the time. And also we'll find out with BMR, you're going to have, this also creates heat, right? So they are always hot, right? They have what, heat intolerance or cold intolerance? Are they always hot or are they always cold? Which one is it? They are intolerant. They don't like hot environments, right? So they don't have the sweater on all the time. They have the sweater off. Whereas your friend who's hypothyroid is always cold, right? They're always like, give me a sweater. It's like it's like 85 degrees. What's going on, right? So that's the hypothyroid person, right? Now, thyroid hormone is released by the thyroid gland, right, in the presence of iodine. Iodine is needed for T3 and T4. T3 stands for triiodothyronine, so triiodine, right? Whereas T4 is thyroxine or ioroxine, I don't know. So it has 4 iodines, whereas the other one has 3 iodines, right? So these are workhorses. These are the ones that are making the beta 1 adrenergic receptors and such. They're the ones that are causing the production of a breakdown of glucose and such, right? So T3, T4 gets released by the thyroid gland, and that's going to be stimulated by a stimulating hormone. Now, if we go back to that one slide with all the different hormones, all the different endocrine system, you'll find out one of those rows is just stimulating hormones. So all stimulating hormones come from the pituitary. If it's a releasing hormone, it comes from the hypothalamus. So it has TRH or GRH or gonadotrophic releasing hormone. All the releasing hormones work on the pituitary, and all the pituitary's hormones really go and work on a target organ, right? So thyroid stimulating hormone stimulates the thyroid. Adrenocorticotropic hormone tropics the adrenal cortex. It stimulates the adrenal cortex to do its thing. Okay, so that's how we look at the pituitary, right? And this is all in a negative feedback. So once I have a whole bunch of T3, T4 around, I'm going to start inhibiting my own release so I don't overdo it, right? So it's all on a negative feedback. Too much T3, T4, then it's going to tell the hypothalamus to cool it down. We don't need too much thyroid hormone anymore. Too little T3, T4, that's going to remove the inhibition of the hypothalamus, and you'll get more T3, T4 as a result. All right. So just key note here, also note is that corticosteroids, they inhibit thyroid hormone, right? So that's something when someone has too much thyroid action happening, they're like hyperthyroid, they're in a thyroid crisis or a thyroid storm, we'll give steroids, and that will inhibit the overproduction of thyroid hormone. Also, you can see steroids here actually inhibit the conversion from T4 to T3 in the tissues, and T3 being the more active form. All right, so it's the one of the most important axes right next to the adrenal glands. with ACTH and such. And just to correct this, this is inhibits, right? So inhibits the hypothalamus and with a cortisol, right? So what happens? What is the normal function of the thyroid? It makes ATP. How do you make ATP? You take glucose and you take oxygen, right? We talked about the respiratory system, right? The whole purpose of the respiratory system was to bring in oxygen so you can break down glucose and make energy. And your respiratory system was to take the CO2 and exhale it, right? You inhale, exhale. That's the one only purpose of the respiratory system. And we take that to the tissues, and our tissues take glucose, which we took in from eating, and that will then produce, some water as a byproduct, but also you produce some heat, right? You get your energy, you also get your heat. So someone's hyperthyroid, they're producing heat all the time. Someone's hypothyroid, they're cold all the time because they're not producing heat, right? So basal metabolic rate and temperature is a way to was what our thyroid hormone does, right? When we want to raise the thermostat, one of the things the hypothalamus does is increase thyroid hormones such that we raise our temperatures a little bit, right? And then SNS activity. We talked about how it is going to upregulate our beta receptors and alpha receptors. It's going to increase the amount of adrenergic receptors there are. It's going to increase the amount of SNS activity. So we have increased cardiac output, increased SVR. Increased SVR has put a lot of work on the heart, and I can even get heart failure with too much thyroid hormone, right? So nerve conduction is nice and increased, including the SNS. I get increased GI activity. These guys have a lot of diarrhea, and I have increased muscle strength and bone growth. So this is kind of more with pediatrics, right? So if a hypothyroid pediatric patient, they need to have thyroid hormones so they can grow properly. They also need thyroid hormone for brain development, intrautero, and the first year of life as well. So you have T3, T4. Those are our workhorses. Those are made with iodine, right? So let's try iodothyronine, as you mentioned, and that's our active form. It's converted at the tissues from T4 by transport, and then at the tissues, they convert it to T3, right, which is the active form. So T3, T4 is released from the thyroid gland, right? Our thyroid gland is what's releasing these guys. Here's a thyroid gland right here releasing T4, T3, right down there. And what else does thyroid release besides thyroid hormone? It's going to also release calcitonin, right? Calcitonin is also released from the thyroid gland. We're not going to talk about calcium balance. We talked about that with CKD, but calcitonin tones down calcium. It's going to reduce serum calcium, right? There's also a guy that has like a little Airbnb. He's like taking the back lot back here, right? On the back of the thyroid gland, we have these 4 little glands. And what are those 4 little glands called? They're like around the thyroid, or they're para to the thyroid. They are the parathyroid glands, which are just taking up shop. They're leasing out some space in the thyroid gland. And those guys raise serum calcium, right? So you have calcitonin and parathyroid. So calcium balance is kind of interwoven here just a little bit. But we're talking more about the thyroid stuff, right? Or thyroid hormone stuff. So talking about primary versus secondary disease. So thyroid is a good example of this, right? You have this negative feedback situation. And when the gland itself is not working, we call that a primary dysfunction. So primary hyperthyroidism or primary hypothyroidism means that my gland is not producing T3, T4, or it is producing too much T3, T4, right? So primary means the organ is at fault. My organ does not have enough iodine to make thyroid hormone. That is a primary hypothyroidism, right? Or my organ is inflamed to the point where it's producing too much T3, T4. That is a primary hyperthyroidism, right? So we have primary hyperthyroidism, my T3, T4 is high. Primary hypothyroidism, my T3, T4 is low. That makes sense, right? And then it's off the chain. It's producing way too much T3, T4. What about secondary? Secondary means it's not the organ's fault. Something else is making my T3, T4 be high, or something else is making my T3, T4 be low, right? So the organ is not at fault. Something else is making it do it. So what if I have a tumor, right? So I have a tumor of the thyroid, making it so my thyroid gland does not produce thyroid hormone. That would be a primary situation. So we're not talking about primary, we're talking about secondary. So it's a tumor somewhere else. Where might it be? What if it's in the pituitary? I got a tumor in the pituitary. It could cause too much TSH or too little TSH. We don't know. It's a roll of the dice. We got to do labs to figure out which one it is, right? So if I have a pituitary tumor that's not producing TSH, what will happen to my T3, T4? Will it be high or low? TSH causes the thyroid gland to do what? To release T3, T4. So if I have a tumor on my pituitary gland and it's making it so I don't release TSH, I'm going to have secondary hypothyroidism, right? So I have secondary hypothyroidism because I had a tumor. My pituitary gland was not producing TSH, right? It could be a hypothalamic tumor. They actually call that tertiary, but I could have a hypothalamus that doesn't work, right? And it's not releasing TRH, thyroid releasing hormone. So you can get a little crazy with these guys, right? And that's where they do follow up with an endocrine doctor to figure out exactly where the issue is, or of course get a CT scan or MRI to see if there's a tumor, right? Or a PET scan to see if there's a tumor. So the TSH or TRH is abnormal. So my TSH TRH is too high. Well, my thyroid gland just follows suit. It's going to do what it's told. So I have a high TSH TRH. That's called secondary hyperthyroidism. It's because I have a tumor that's releasing too much TSH from the pituitary or too much TRH from the hypothalamus, right? So I have a high thyroid release and secondary hyperthyroidism because there was a tumor, right? Causing too much TRH or TSH being released. Whereas if I have too much T3, T4 being produced by my gland or not enough produced by my gland, what's going to happen if everything's normal? Well, if I have a lot of T3, T4, that should inhibit this, right? So primary hyperthyroidism has a TSH that is low because my pituitary is working. It's like, whoa, it's way too much T3, T4. I stop it. And they're going to keep going down, keep going down, keep going down. But I have too much being released because the thyroid is at fault, right? Or vice versa. My thyroid gland is not producing T3, T4 because it has an inflammation, it has a autoimmune attack, it has it could have a tumor too, but there's not T3, T4 being produced. The T3, T4 is low. What's the response by my body? It's going to, my pituitary hypothalamus is going to say, whoa, why is the T3, T4 so low? Let's increase that. So you're going to see an increase in TSH. So that's how they interpret these tests. And usually we just do like a surveillance, so just a quick TSH level to tell us if there's a problem, right? So whenever someone comes in with AFib, why would they have AFib? Well, if their thyroid gland is out of control, making too much T3, T4, we're going to see a lot of SNS activity and maybe even AFib. So you'll see a TSH ran on these patients, and it can tell you if there's a problem or not, right? If it's normal TSH, well, it's not primary, secondary, tertiary, quaternary, or it's, what's 5, sexternary? I don't know, right? Septenary. The TSH is fine, right? It wasn't that. Okay, so that's why we look at TSH first. And if the TSH is weird, it's too low or too high, then we'll follow up with a T3, T4 to figure out who's at fault. Is it the thyroid at fault, or is it the brain at fault, the hypothalamus or pituitary? So goiters. So goiters are a swelling of the thyroid gland, right? And why does that happen? It happens when you have a TSH receptor that's being stimulated way too much. So we have a TSH receptor right here that gets stimulated by TSH, right? And if you are stimulating that way too much, you keep poking that button, you keep ringing the doorbell and ringing the doorbell and ringing the doorbell, the thyroid gland's like, what the heck? Let me just beef up a little bit. Let's make more T3. Let's go ahead and increase our production size. Increase. We need more TSH. We need more T3, T4 because obviously TSH keeps stimulating me, keeps stimulating me, keeps stimulating me. So I'm going to get an increase in size of my goiter, increase the size of my thyroid gland when I have too much TSH around. And that could be because of a tumor on my pituitary gland, right? I got too much tumor happen over here, too much TSH. Yeah, that could cause a problem, right? Because my pituitary gland obviously is not going to respond to too much T3, T4. But usually why this happens is because someone is deficient in iodine. So the iodine is deficient. I need iodine for what? Iodine's for triiodothyronine, it's for thyroxine. I need all of that to make T3, T4, right? If I don't have iodine, I don't produce T3, T4. And what's the pituitary gland going to say? It's like, whoa, where's the T3, T4, bro? So we need to make more T3, T4. So let's release more TSH, and let's go ahead and make your goiter much bigger. Maybe if I make more thyroid gland, you'll make more T3, T4. But they're like, I don't have iodine. How am I going to make more T3, T4? I need iodine. right? So iodine comes from seafood. If you look at a picture of the U.S., there's a perfect picture right here, by the way, right? And you got Florida down there, right? You got Mexico, right? And you got Canada up there, right? So we on the coastal areas, that's where you get fish, right? That's where you get your fish from that has iodine. So it wasn't until like the 1920s, 19 teens, where they discovered that you need iodine for thyroid function. When I give iodine to someone that has a goiter, well, lo and behold, they can make thyroid hormone, and the TSH will go down. I'll stop hitting the doorbell, and my goiter goes away, right? So what do we say thyroid function was for? It was for mental acuity. It might make you anxious if it's too high, but you need to have thyroid to be smartish, right? So in the 1923, 1924 year, they put iodine in salt, Morton's iodized salt. And it's been iodized since then because here in the Midwest, right here, there's a good color right here. In the Midwest, you have to travel, how far? When did the airplane get discovered? 1918, right? So, it took a long time to get from the Midwest all the way to the coast to get your fish. And if you had someone fish, you trained it over, right? With a great, over the train tracks. It's going to take you a while. The fish is not going to taste great, right? They might have sardines. Cool, but that's not very palatable. So, when you iodize the salt, and now the Midwest got the salt, their IQ went up 3.5 points, right? So when we iodized salt, we actually improved the Midwest and we reduced rednecks because of just iodizing it. That's all we had to do, okay? So iodine deficiency will cause goiters, all right? Poor intake of iodized salt or poor intake of fish will then, yes, cause a lack of T3, T4 production and therefore hypothyroid. And that's a primary or secondary hypothyroid when I have iodine deficiency. Which one would it be? Good. Primary iodine deficiency because my thyroid is not producing T3, T4. It's their fault. Therefore, I'm going to see a rise in TSH because I have a primary hypothyroidism. So what else? So hypothyroid, iodine deficiency, and then a unique thing is Graves' disease. Graves' disease is very, very unique because usually when you form an antibody against something, it causes inactivity of that something. It causes destruction of that something, right? So when I have like glomerulonephritis, my antibodies against the strep also attack my glomerulus, make my glomerulus not work. Or when I have I don't know, I have like, what's another similar situation where I have antibodies like rheumatic fever, I'm attacking my valves, right? So, but in a Graves' disease, I'm not attacking the receptor, I'm actually stimulating the receptor. It's one of the unique diseases where the antibody that gets formed, actually, this autoimmune situation, it's actually TSH-like. It actually stimulates and overstimulates this goiter. So you can have goiters with hypothyroidism, which is most common, or you can have goiters with hyperthyroidism, but only one hyperthyroidism, and that's Graves' disease, is where you would get a goiter. Okay, so goiters does not always mean hypothyroidism. It just means like 80% of the time it is. Okay. So hyperthyroidism or thyrotoxicosis, right? So I have too much thyroid hormone. These guys are hot or cold?
Too much thyroid hot.
They're really, really hot because BMR is extremely high. They're producing a lot of CO2 and water, but it also produces a lot of heat, if we know our formula for cell respiration, right? So they're producing a lot of thyroid hormone as well. And it could be two reasons. So like Graves' disease, right? Usually you would think Graves' disease, I have an autoimmune attack of my receptors, my organ should not work, right? But it's TSH-like. It's actually going to be stimulating the TSH receptors a lot, causing a goiter, but also causing a increase in T3, T4, right? So Graves' disease causes a TSH receptor stimulus, which causes hyperthyroidism, right? Is Graves' disease hyperthyroidism? No. Does Graves' disease have symptoms of hyperthyroidism? Yes, right? So sometimes they interchange them. It's like, oh, you have Graves' disease. You must have, that means that, or you have hyperthyroidism. That must mean you have Graves' disease. No. Graves' disease is, TSH-like receptors, but also those receptors go to the pretibial area and cause a little bit of mixed edema. So you have this pretibial mixed edema that happens, or this non-pitting edema that will occur with only Graves' disease. Does this happen in hyperthyroidism? No. Hyperthyroidism is just too much T3, T4. But these antibodies situation are going to start causing a preteal mixedema. And what else do the antibodies do? They're also going to cause exophthalmos. Does every person with exophthalmos have hyperthyroidism? Maybe, but there's some other reasons for it. But does every person with exophthalmos have Graves' disease? They could. It's a very common reason for it. And those patients with exophthalmos and Graves' disease, yes, have hyperthyroidism. But is every hyperthyroidism person that's thin and seeking out food and sweating all the time and having this heat intolerance have exophthalmos? No, they are not interchangeable, right? So these two symptoms are only under Graves' disease. Otherwise, it's just hyperthyroidism. And why would you just have hyperthyroidism? Tumor. That's the most common reason, right? I have a tumor that's producing too much thyroid hormone. I could have tumors that make it so my thyroid shuts down. That could happen too. And then you have viruses, usually post-viral syndromes. They'll have this, they'll lead to a thyroiditis, inflammation of thyroid gland, and cause excess thyroid hormone to be produced. That's also something that can happen. And what else regarding this? So preteal mixedema is a feature of Graves' disease, and Graves' disease has a feature of having hyperthyroidism, right? But you don't have exophthalmos in every hyperthyroid patient, right? And then to make it even more confusing, mixedema is also synonymous with a hypothyroid crisis. Hypothyroid, yes. Hypothyroid crisis causes mixedema. Does a mixedema crisis have preteal mixedema? No. So it's like, guys, why did you do this? Who are the hematologists in the room, right? So they're not, they didn't name it properly, and no one wants to take credit for it and rename it, right? But it is what it is, all right? So that's the idea with hyperthyroidism, all right? Most common is Graves' disease, an autoimmune attack of the thyroid. And we can measure those antibodies to see if they have that disease process. And of course, we look at TSH and T3, T4 to see what's going on. We say, oh shoot, there's a whole bunch of TSH, or sorry, there'd be too much to T3, T4 because it's the TSH receptor is being stimulated so much. And we're going to see a really, really low TSH in Graves' disease because there's so much T3, T4 around, right? So a low TSH, a really, really high T3, T4, all right? T4, and then you have this unique situation where you have that goiter, which is the only reason why you would have a goiter with hyperthyroidism is with Graves' disease. And also you have this preteal mixedema and this exophthalmos. That's very, very unique to Graves' disease. So what are your symptoms and diagnostic tests? We talked about diagnostic tests would be your TSH. TSH can be low or high in hyperthyroidism. It could be primary hyperthyroidism, where you'd have a low TSH, where you have a tumor, right, that's happening, or a viral syndrome, or you could have low TSH, where I have like have Graves' disease, where I'm producing way too much T3, T4, but and the pituitary is responding appropriately, right? And we have follow-up tests. We can do like we talked about the antibodies you can do, and then we can sometimes it's rare. That's why you want to invite an endocrinologist. There's something called subclinical hypothyroidism, where everything looks a little bit normal. There might be just very, very low T3, T4 or high T3, T4. So we look at those things with the endocrine's help. Okay, this summarizes hypo and hyperthyroidism here. What you would see like hyperthyroidism, where I have just straight up high T3, T4. The normal response is I should have a low TSH. It could be someone who just took too much of the thyroid medication. So I'm going to see, well, that's the reason. You took too much of the thyroid medication. That wasn't dosed properly, right? Or vice versa, they didn't take enough of the thyroid medication. They're hypothyroid, right? That's a primary hypothyroidism. So, and then we can look at, is there just Graves' disease, right? Or is there a Hashimoto's, which we'll get to next, which is when you have a hypothyroid from inflammation of the thyroid. Okay, usually with hyperthyroid, they start getting like skin and hair manifestations. There's all kinds of fancy skin and hair manifestations you're going to see with the ophthalmologist first. So they're going to usually be the first ones that discover it, and then they get followed up with endocrine to get some more testing to see that they might have a hyperthyroid state. All right, so hypothyroid. Does hypothyroid have preteal mixedema? No. But does hyperthyroid have preteal mixedema? Yes. Does hyperthyroid have mixedema, coma? No. Does hypothyroid have mixedema, coma? Yes. So again, it wasn't named properly. No one wants to take credit for it. But these guys with a crisis of hypothyroid can get a mixedema, coma, where everything starts shutting down. Before it shuts down, before we go into crisis mode, we're going to have reduced thyroid hormone. We're going to have a reduced temperature generation, reduced heat generation, right? So we're going to have low T3, T4, all right? And low T3, T4 could be due to the organ itself, due to the thyroid gland not working, or it could be due to the pituitary not releasing TSH. One of the two reasons. It's either primary or secondary, right? So I got a pituitary gland that's not releasing TSH. That makes sense. I got a tumor on a pituitary, right? Or I took the pituitary gland out because they had a tumor. That's going to cause less TSH and less T3, T4 by association, right? Because TSH is what releases T3, T4, stimulates T3, T4. Most common cause of hypothyroid, though, is a Hashimoto's thyroiditis, where we have antibodies against the erythroid thyroid, against thyroid production as well. So we have this Hashimoto's thyroiditis, which is causing a lack of T3, T4 being produced because our systems that make T3, T4 are literally being inflamed and irritated, right? It's not like post-viral thyroiditis where it's actually making more upregulation. It's actually destroying some of the processes inside the thyroid. Okay, so these guys are going to have this myxedemic coma as a ultimate consequence if we don't catch it early enough. These guys get very, very lethargic and comatose to that point. But before that, they'll have a very, very hoarse voice, not like a neigh horse, but a hoarse as in a very, very low voice. And it's very, very very prominent. When you see someone with hypothyroidism, their voice is extremely low. It's like, oh, sir, how you doing? And you realize it's a full-on woman, right? So it's like they have this this increased body weight. They might have increased hair production. They have all this, and they have a huge, huge tongue, which is very, very unique to hypothyroidism. Okay, so that's the idea behind hypothyroid, right? And anybody's cold in the ICU, automatically you should be checking a TSH, right? Because with chronic illness or critical illness, ICU stay, you can have a very, very prominent or a very, high development, high risk for developing hypothyroidism, or it's called subclinical hypothyroidism as well, but it's called, thyroiditis, not euthyroid, I forget the name of it, but it causes a drop in thyroid function because kind of like you used it up almost, right? And they're not getting, and all these processes are being overhauled or overstimulated for a prolonged period of time, and they kind of just peter out their thyroid production, and they can develop a thyroiditis in the ICU. All right, so anytime someone's cold on the floor or in the ICU, we should be checking a TSH to make sure it's not the thyroid that's getting damaged. All right, so hypo and hyperthyroidism. So we have a thyroid crisis of some sort. And both situations are going to be very, very altered. The hyperthyroid patient might get really, really anxious first, but basically you have too much thyroid hormone or too little thyroid hormone, and now it's gone over the edge, and we have to fix it, right? So if they have too little thyroid hormone, what do you got to do? You got to give thyroid hormone, right? You give T3, T4. You can give either one, actually. You can give thyroxine, which is T4, or you can give triiodothyronine, which is T3, right? T4 is much safer to give than T3. T3 is going to induce AFib if you didn't already have it. It's like the activated form of thyroid, right? So it's going to definitely cause a lot of problems if you don't know what you're doing. So usually T4 is what we'll give if someone's super cold and we realize their TSH is super low, and the T3, T4 was super low, and they're comatose in front of me, they're intubated, they had a hoarse voice ahead of time. So that's where we give thyroxine. We give T3 or give T4 first. And we also give and that can happen, especially in the ICU, because maybe they are on steroids. And what did steroids do? Steroids they caused a low T4, right? They inhibit T4. They don't inhibit a low T4. They cause a reduction in thyroid production. And we know a lot of patients in the ICU get a lot of steroids. They get high dose steroids, even in septic shock. And septic shock itself can cause hypothyroidism. So it's a double-edged sword. That's why we want to definitely check to make sure they're don't have a hypothyroid situation with a shock state as well. Okay, so looking at the underlying cause, what caused it? Was it a prolonged ICU stay? Was it because they weren't taking their medications that caused me hypothyroid? Might be what we have to look for to see if we can try to find something that's easily reversible, right? Like, is there an antibiotic we could give if they have a thyroiditis? And then what else? If they have a hyperthyroid crisis. All right, they're super hyperthyroid. They're probably might present that way, where they have that classic, thin body appearance. They have the heat intolerance and such, or they could just have a severe AFib RVR or PSVT, or even a ventricular arrhythmia that's very fast, and they're extremely febrile. Right? When someone's temperature is extremely high, more than 103, you're always thinking worst case scenario, it could be a thyroid storm. It could be too much thyroid hormone. Is it common? No, it's extremely rare to have a thyroid storm, but you always have to worry about it, right? Other reason why your temperature might be high is because you have like a neuroleptic malignant syndrome, or you have a patient that's post succinylcholine has malignant hyperthermia, for instance, right? So those are the common reasons for really high temperature. Okay, so hyperthyroid, you have a thyroid storm that's developing. So going back to hypothyroid, you can see here this patient came in like this, and we replaced her thyroid hormone, and she looked almost brand new. All right, so thyroid storm, they're extremely febrile. Do you give aspirin? That's not indicated, because the aspirin is going to move the thyroid globulin. So you got aspirin right here on top, or so I got T3, T4, or T4, right? Be on my transport proteins through the body. And what does aspirin do? It's going to displace that. It's going to move the T3, T4 off, and it's going to raise your thyroid hormone exponentially, right? So aspirin is actually contraindicated. With someone's febrile, you give Tylenol instead. These patients are extremely tachycardic. They're extremely hypertensive as well. We usually give broad or non-specific beta blockers like propranolol. That's going to help, abate the symptoms. It actually also inhibits the conversion of T4 to T3, which is good. And steroids. Steroids inhibit the conversion of T4 to T3, and also steroids are going to inhibit TSH and inhibit the thyroid function, right? So that's why steroids are critical and actually first to be given. So not third or fourth, but first line when someone has hyperthyroid. You give steroids immediately, give them Tylenol, and give them beta blockers. They're extremely tachycardic, and then we can get them under control, hopefully, and then we can figure out the reason is, and do we have to make it so that the thyroid stops producing thyroid hormone? How do you make the thyroid stop producing thyroid hormone? You can give it a whole bunch of iodine. Give it a whole bunch of iodine. Say, whoa, I have way too much iodine. I don't need to make any more thyroid hormone, is what it'll be thinking. Or you can give PTU or methimazole. PTU is very liver toxic, right? So liver toxic. But otherwise, these two drugs are going to go directly inside here and are going to stop the production of our thyroid hormone. So that will kind of abate the thyroid crisis from getting worse, right? We're going to treat the symptoms first, and then we try to figure out what the underlying cause is.